Okay. Okay, small child. Well, hello, Miriam. Nice to see you. Yeah. Uh, Let me see if we are recording. I think we are recording. Do you see the sign that we are recording? Yep, everything is fine. Okay. Now, thanks for joining us this evening. It is a fairly late start, but it's intended to meet all the obligations that many of us have had during the day. Our topic today is the link between the borderline personality disorder and the psychoanalytic phenomenon or concept or methodological perspective, which is called displacement. Displacement, and we are lucky to have Miriam with us because she is an expert on psychoanalysis and has done her master's degree on psychoanalysis. So this is this is all very familiar to her. Now I propose that we start with a very brief laying out of the basic concepts and then open a discussion to see whether we can sort of go through some of the main perspectives on borderline personality disorder, which, as you know, is arguably the most controversial diagnosis in modern psychodiagnostics and also one of the more prevalent ones. Now, in psychoanalysis, there's this concept, especially in the structuralist and post-structuralist psychoanalysis in Jacques Lacan and his followers, there's this concept that the insufficiency of language, the basic inadequacy and insufficiency of language as a symbolic medium generates what psychoanalysts call the epistemological inability or impotence, because we are never able to convey the full extent of our messages which we direct to other people. Whenever we want to convey some kind of context, whenever we want to effect a high quality conversation, communication, we always necessarily fall short of conveying everything that we want to say. And this gap in language is reflected in our symbolic world, so that our symbolic world, which relates to the symbolic world of other people with whom we communicate, is also deficient. And this deficiency creates what psychoanalysts call displacement, which means that we always have to count on a certain twisting of the meaning and a twisting of the subject which we want to encompass in our communication. Now, there are various interpretations of what displacement is, but fundamentally displacement is the way in which we decide to interpret the world and our experience within a perspective which we as psychoanalysts, which we know is in a sense warped, to an extent warped. The perspective is always bent, it is never straight, and it is never such that it encompasses all of the relevant meanings. Now, modern psychoanalysts often explain displacement by referring to old Freud's concept of psychosis as a theory. In one of his works, Freud wrote, when he wrote about his famous patient Schreiber, the paranoid schizophrenic, Schreiber was the inspiration for most of Freud's work. In one of his writings on Schreiber, Freud describes his paranoid ideation of the world, and he says that sometimes he wonders whether the ideation of a psychotic is any less legitimate a theory of the world than the theory of us who agree on what is real and how to properly interpret it. Whether the mental disorder, whatever a level of disorder is at stake, is only a different theory which deviates from a consensually validated right or proper or correct or true theory. And Paul Verhaag, as one of the most dominant Lacanians today, goes a step further and he writes that this means that for psychoanalysts, the truth does not reside in the realm of epistemology, and that in fact in psychodiagnostics and psychoanalytic psychotherapy, the truth really lies in the realm of ethics, that when we talk about the truth, we shouldn't be talking about the true or less true theories of reality, and that we should rather talk about the true or less true value systems and ethical judgments of our own experiences, decisions, and actions, and our own judgments, right? Which then position our experience and our discourse in what most people would consider normal, or in what most people would be considered mentally disturbed or dislocated from this consensual matrix of normalcy. The cluster B personality disorders, including the borderline personality disorder, are perhaps the most relevant for discussing this Verhaag's concept of the truth lying in ethics rather than epistemology, because they are often described as the ethical or moral disorders. Unlike the cluster A and cluster C personality disorders, the four cluster B personality disorders, of which the borderline personality disorder is arguably the most complex, are often described as mental disorders which are not defined or diagnosed by the use of clinical concepts, but rather by the use of exclusively moral concepts. And this famous paper by Louis Charland on the moral nature of personality disorders describes this particularly well, where he basically examines the DSM terminology and the DSM criteria for the diagnosis of cluster B personality disorders, especially the borderline, and finds that there are basically no clinical concepts there, and all of the concepts are moral. And this is particularly relevant from the point of view of the psychoanalytic perception of displacement, because it opens up all kinds of questions of how we could interpret the borderline personality disorder. And just to kick off our discussion, I would like to simply read to you the diagnostic criteria for borderline personality disorder to examine at face value what Charland says about their moral rather than clinical nature. The criteria as follows. This is DSM-4 that I'm now reading. Beginning by early adult life, the patient has unstable impulse control, interpersonal relationships, moods, and self-image. These persistent or recurrent qualities are present in a variety of situations and shown by at least 5 of the following. And then goes the list. Frantic attempts to prevent abandonment, whether this is real or imagined. Unstable relationships that alternate between idealization and devaluation. Identity disturbance or severely unstable self-image or sense of self. Potentially self-damaging impulsiveness in at least 2 areas, such as binge eating, reckless driving, sex, spending, substance use. Self-mutilation or suicide thoughts, threats, or other behavior. Severe reactivity of mood leading to marked instability, mood swings of intense anxiety, depression, or irritability lasting a few hours to a few days. Chronic feelings of emptiness, anger that is out of control or inappropriate and intense, demonstrated by frequent temper displays, repeated physical fights, or feeling constantly angry. Brief paranoid ideas or severe dissociative symptoms related to stress. Now, if we look at the list and see that at least 5 of these features need to be exemplified in order for a diagnosis of borderline personality disorder to be established, then we basically see that we are dealing with a very large number of potential candidates for this diagnosis, and this is the reason why in initial interviews so many diagnoses of borderline personality disorder are made. And this is why this diagnosis is sometimes described as a catch-all diagnosis, where many other cases which cannot be adequately classified are described as borderline personality disorder. Now, my worry about this and my question, perhaps my initial question to kick off the discussion, is really whether we can distinguish one personality disorder from another personality disorder if we start from a position which psychoanalysts generally assume, and that is that any mental disorder is a sort of a perspective on displacement. And what specific displacement characterizes borderline personality disorder as opposed to, for example, narcissistic personality disorder. There's a narcissistic personality disorder which is described by many of the same criteria as a borderline personality disorder, as is the antisocial personality disorder. Now, can we distinguish between these categories and whether our distinctions are arbitrary? Why are 5 of the list required for the diagnosis? Why not 4 or 3 or 6? Why is it 5? And how do we arrive at our diagnosis? Is our diagnosis anything more than a conventional way of describing something that bothers us aesthetically, something that is seen as sufficiently deviating from the conventional standards of normalcy that it disturbs us? What can we say about people who can be considered to satisfy these criteria? How would we describe them in what Fahad calls the realm of truth in ethics? How would we describe those people morally? Does anybody have any view on this or any comment? Frantic attempts to prevent abandonment, whether real or imagined. How many people do that? In our counseling practice, we often encounter people with such behavior, right? Then unstable relationships. How many people have unstable relationships? Especially those that alternate between idealization and devaluation. This is what is called the black and white world of the borderline patient, where at one point you are the ideal therapist. You are the epitome of wisdom on earth. You are the most important, the most empathetic, and the most valuable person in their lives. And a day later, you are a charlatan, an egotistic, even sadistic person who exploits their loyalty and who denigrates their qualities. And this is the reason, this behavior is mainly the reason why most psychotherapists avoid, whenever they can, avoid working with borderlines. Now, what kind of moral qualification does this kind of behavior meet? If we didn't have the criterion of borderline, what would we consider? What would we say about this person, such people? How would we morally value them? Then the identity disturbance, severely unstable self-image or sense of self. There are people that we work with, very many people, who go to incredible lengths in inflicting pain on their close ones, because inflicting pain is their way of affirming their own value. This is this famous equation which says the more you suffer, the more valuable I am. The more you miss me, the more valuable I am. The worse your life is after splitting up with me, the more valuable I am. And to the extreme, the less you want to live after having split up with me, the more valuable I am. This is a highly destructive way of trying to stabilize one's self-image, one's perspective on one's self-worth, based on one's negative relationship to the other, on one's oppression, emotional oppression of the other. Now, we've discussed this in our previous seminars, and some of these discussions really bear very strongly on how we perceive the theory of the borderline person. What is the theory of the borderline person? What is the moral theory of the borderline person? Does the borderline person have a moral perspective on their actions, on their choices, and on their decisions? Does the borderline person have a value relationship to their own choices and decisions? What do you think? And if they don't, then how does that differ from schizophrenia? How does borderline differ from psychosis if they don't appreciate their actions in a way which is even remotely connected to the values that the mainstream community attaches to their actions and their choices? Because one of the diagnostic criteria for borderline in clinical practice is that they don't have a relationship to their actions. They don't show remorse when they do something bad. They don't show empathy. They show emotions, which is sometimes, the way they show emotions is sometimes described as emotional hemophilia, as uncontrolled bleeding. They can't control their impulses, their affect. And especially when they're angry, they often let that anger completely, fly out of control. They cause all kinds of incidents. They often have conflicts with the law because of that. But they don't have a relationship to an internal structural relationship to their own choices. And one of the problems with borderline patients is that when they have those episodes, they quickly subside, and the conditionally speaking normal state returns fairly quickly. And by the time the emergency medics arrive, or the police arrives, or any institutional help arrives, the situation has often already subsided, and it's very difficult to hospitalize them. It's very difficult to, establish a long-term pattern of ideation and or experience or thought that can be diagnosed as psychosis. But is it structurally different from psychosis? And Verhaag has this idea, which we have all read, and that is that, in fact, the borderline personality disorder is a conventional replacement for what used to be called mild schizophrenia. And that the working group under Gunderson, while working on the introduction of personality disorders, cluster B personality disorders in the DSM-3, basically had a task to reduce the volume, to reduce the scope of psychosis by introducing various personality disorders, diagnoses of personality disorders, which could replace mild psychosis. And then one of the key theses by modern Lacanians is really that, the borderline personality disorder is in fact schizophrenia, and that the fact that it is distinguished from schizophrenia by the severity of the symptoms is unjustified from the structural point of view, because the level of the volume of the symptoms cannot be an essentially part of a definition of what something is. The fact that I have a very severe cold as opposed to very mild bronchitis does not mean that my severe cold is a bronchitis, or that my mild bronchitis is not a bronchitis, but only a cold, right? The level of the symptoms in structural psychoanalysis, the level of symptoms cannot be the criterion for diagnosis. Because if by psychoanalytic lights, if the structural root of neurosis is the blockage of the socializing signifier, socializing function name of the father, in the Lacanian perspective, and the structural root of psychosis is the elimination or destruction of the socializing signifier role of the father, then the interventions are fundamentally different in neurosis and psychosis. And something that is on the border between neurosis and psychosis, as is often thought of borderline personality disorder, is then not susceptible to adequate intervention, because we have to decide what it is structurally. And in many modern papers and books about borderline personality disorder insist on this concept of a literal borderline, where someone is neurotic and then develops psychotic episodes and crosses the boundary into the psychosis, and then quickly the symptoms recede and the person returns to the neurotic state for which psychoanalysts believe that we are all basically living in, that we're all neurotic. Now, does this help? Why are borderline patients so different from the rest of us neurotics? Is it, as Verhaag says, because they are in fact psychotic? Because they suffer from what used to be called mild schizophrenia? And is that the reason why antipsychotics are often helpful in treating borderline personality disorder? And is this perhaps the reason why the psychoanalytic interventions in the psychotic theory of the person, which has its ethical repercussions and ethical dimensions, are often helpful in the form of psychotherapy? For example, if you work with the paranoid schizophrenic who is under medication and thus under control and thus able to maintain a meaningful conversation, and thus a candidate for psychotherapy, right? If you work with such a person, then you can discuss his psychotic theory with him or her. You can discuss his views, and to some extent, you can argue and reason with the patient or with the client about their theory. And if we remember the psychoanalytic idea that the symptom, even delusions in psychosis, are a way of stabilizing our experience, that they are a stabilizing tool to prevent the unmitigated onslaught of the real, of the unbearable real experience, which would otherwise completely disorganize the person. Then even the paranoid schizophrenic ideation is a theory of reality which allows us to consolidate our symbolic resources and symbolic views of what is otherwise unbearable to us and thus stabilize us. Now, this is remarkably similar to theory in science, because the theory in science allows us to organize our information, to organize our knowledge in a way which can be systematically applied to explain various phenomena. In the same way, paranoid ideation can organize one's perceptions and one's views of reality, which can allow a person to function to a degree. And this is connected with what we discussed previously, and that is the concept of a catastrophic outcome in psychotherapy. And Verhaeghe is very clear on that. He says, suicide, which is often considered to be the only morbid outcome in psychiatry and psychotherapy, in the psych professions, as he calls them, suicide is not the catastrophic outcome, because for a person, in order to commit suicide, the person must have a relatively high degree of symbolic organization and ability to execute actions. The person who commits a suicide is not a fully disorganized person, because in order to be able to commit suicide, considerable structure and ability to act must be preserved. Whereas what Verhaeghe calls the catastrophic outcome is catatonia. Catatonia is a complete psychic disintegration, which results in a loss of control of our bodies. And catatonia is the ultimate level of disorganization where we can no longer do anything, including committing suicide. So if we take this perspective, the perspective where our contact with the real which always escapes us, which we can always access only through the resources of our symbolic world, of our symbolic register, if our contact with the real is so unbearable that it transcends the symbolic resources of our person, and thus the onslaught of the unmitigated real threatens to completely disorganize us, then our various forms of ideation, including symbolic processing of our raw experiences, will serve as a theory which will allow us to symbolically interpret that unbearable real, to give it meaning, and thus allow us to more easily psychologically metabolize the experiences which would otherwise be fatal and completely destructive for our person, for our personhood, for our subjectivity. Now, if this is so, then, my theory as a psychoanalyst is on the same level of being an instrument of allowing me to process my experiences, deal with my clients, deal with what I study, as a schizophrenic's theory of paranoid ideation, as Schreber's theory. And just as you might be able to argue with me about my theory and question my theory whilst being careful not to undermine other pillars of my stability, so that you don't throw me into an irrational resistance to your arguments. You have to be tactful in order to, question the basic pillars of my theory. You have to offer me an alternative. In the same way, in psychotherapy, we take care not to dismantle a psychotic symptom, assuming that that symptom serves a stabilizing role for what would otherwise be a more or less complete disorganization. And we try, when these symptoms are particularly damaging, we try to tackle them, to sort of knock on them, to touch them, to move them, to loosen them, while at the same time offering the client something else to lean on, to offer them a clutch to lean on, whilst we remove what might be a current stabilizing ideation or thought or reaction or emotion. Now, this is a process which is very similar methodologically to the process of challenging theories and replacing them with other theories, of challenging one paradigm of viewing the reality and replacing it with another paradigm. Now, can we do that with a borderline patient? If the borderline patient is driven by values which are disturbing to the rest of us because they are ethically offensive, they are not empathetic, they are egotistic, they don't control their affect, how do we work? How do we argue with such a theory? How do we argue with someone who believes that once they have a diagnosis and once they have a confirmed reduced level of control of their affect, that they are, in virtue of that fact, entitled to a less considerate action towards others than people who don't have a diagnosis? In many people with BDP diagnosis, they the first thing that they say is, I have a borderline personality disorder, and therefore I did that and this, right? I did some things because I have a diagnosis. And it sounds almost as though they believed that they were entitled to do that because they had a diagnosis. Freud had this idea somewhere in his writings that there are ethical limits to mental illness, and that even people with psychosis should be considered to some degree responsible for their actions, because our falling into a psychotic ideation is also something that is within the ethical parameters of what we consider to be acceptable. And these ethical parameters change and shift and can be fluid in situations where our encounter with the real is so painful that we are willing to allow ourselves more than other people would allow themselves. But they still exist. They are not removed. As long as there's a socializing signifier, as long as there's a concept of normalcy, as long as there's a concept of a convention from which we deviate, there's a standard, and you can deviate more or less. But the concept never disappears unless we are in a state of disintegration, which is characterized by a catastrophic outcome, and that is catatonia. So we always have some perspective, whether we acknowledge it or not, whether we are emotionally aware of it or not. But we have a perspective that what's going on with us is not entirely okay. And this is why people come for psychotherapy. They come to psychotherapy because they feel stuck. They feel that they have problems in their relationships with others, that their functioning is obstructed or limited, and they understand that this is somehow related to their views, to their ethical values, to what they allow themselves to do, to their perspectives, to the way their displacement works. Now, correcting that displacement to a more, what psychoanalysts would say, to a more acceptable displacement, because we all have a displacement in our views of the real, right? Correcting that displacement requires arguing with a theory. And to what extent do you think arguing with an ethical theory is the methodologically promising way of working with borderlines, if we assume that cluster B personality disorders are justifiably described as moral personality disorders, as disruptions in the moral structure of personality? What do you think? If we assume that we can talk to a psychotic and it makes sense to have a meaningful therapeutic discourse with someone who is schizophrenic, then is it meaningful to talk to a borderline person? given that the borderline person claims not to be psychotic and is not characterized as psychotic and is often highly functional in society. They're often very ambitious and they're often full of energy and they're often very able to get their own way in ordinary social contexts. So they are often on that side which the society in some aspects would even commend. They can be very charming, they can win people over very easily in very manipulative ways. So they have all kinds of qualities which set them apart from what we would conventionally consider psychotic behavior. Now, talking to a borderline, for example, who wants to prevent abandonment at any price, whether the abandonment is real or imagined, what would it be like? We often have patients or clients in our practices who have issues in relationships and who cut themselves and harm themselves physically, which is one of the defining features of borderline, especially cutting themselves on lower arms, because they want to mitigate the psychological pain which they feel from the thought of the possibility of being abandoned by their parents, by their partners. We often have people who engage in warfare with their former partners in order to punish them for having abandoned them, whether they actually had been abandoned or they abandoned the partners. But their sense of self-worth has been so damaged, so disturbed by the perceived abandonment that they are willing to go to extraordinary lengths to teach a lesson, as they say, or to pay back the person for abandoning them. Now, in this context, we had this theory earlier in the beginning of psychotherapy. The founder of the psychotherapeutic clinic, Philippe Pinel, had this idea that any psychotherapy is, in essence, a moral re-education. Now, to what extent is a moral re-education possible with borderline clients? How do you proceed with moral re-education? How do you proceed with trying to induce in them a value-laden awareness of the significance and meaning of their choices and actions vis-a-vis the other people? Do you do that by trying to rationalize with them? Or do you do that by providing stimuli, either positive or negative? Or do you do that by punishments? There's this paper by Pat Carlin, a famous British criminologist, who argued that people with personality disorders should be told by the state about the values of their choices and actions. And the title of the paper is How to Say Things with Walls. Now, is that an acceptable form of moral re-education? Assuming that the question is, Miriam, assuming that the question is about how to reach the borderline person, would it make sense to bring up rejection-sensitive dysphoria? I read an article once that was very beautifully written about the pain of possible rejection. And from there, about how many different things could be perceived as possible rejections. Yes, how many different things can be perceived as a possible rejection? Because anything that we do, right, all the relationships that we enter contain a value element, contain an element of valuation. When you choose me as a friend, it's a valuation. When you don't choose me as a friend, it's a valuation. When you decide to enter into any kind of relationships, or when you take any action within an existing relationship, it's always a valuation. It's a constant stream of judgments and valuations. And if I am sufficiently focused on the negative variations, I can interpret them as rejections. And I can dramatize them sufficiently for them to justify in my own mind all kinds of strange decisions that I may make. Now, Freud would say I can push myself into psychotic ideation and psychotic interpretation of relationships and reactions that I'm surrounded with, but I still retain a degree of ethical responsibility for what I do. Now, do borderlines have an ethical responsibility for their perceptions of rejection? On your deathbed, Miriam writes, how would you like to look back on your life? Yeah, it's a famous existentialist question in psychotherapy. How would you like to look back on your life? Yeah, I recently had a contact with a person who has been described as borderline by many observers, and whom I believe to be, in fact, more narcissistic than borderline. And that person was in conflict with their very close relatives. And in one situation, to the amazement of the relatives who were there, she said, I am currently in a situation in my life where I am fighting for my family. She was at court with her closest family members, and she was perceived by most of her family members as destroying the family. And in her mind, she was fighting for her family on some level. This is obviously a displacement which is very different from the conventionally acceptable scope of displacement of perceptions of what one wishes to achieve. Now, obviously, it's a theory, right? A theory of her action, a theory of her relationships with her close ones, which is very different from the theory that those very close relatives would consider normal. Now, we can interpret that in different ways. And Fahad has this interesting idea. He says, whenever we are tempted to enter into psychodiagnosis, we always provide a psychodiagnosis of ourselves, because the way we interpret one's displacement depends on our own displacement. So when I look at this person or other persons who are described by many psychodiagnosticians as borderline, and when I see in myself an inclination to interpret that as a narcissistic rather than borderline, then I wonder what my displacement is that reflects in this kind of propensity for such a diagnosis or such a description, to avoid the word diagnosis. Now, by ascribing certain characterizations to our clients, we speak about ourselves at least as much as we speak about our clients. But still, we need to cling to some kind of vertical axis, to some kind of axis of conventional normalcy, in order to pull the person toward that standard of normalcy, in order to be able to effectively communicate rejection of rejection, or negative valuation of violence, or social stigma attached to poor impulse control. We need to be able to communicate that by referring to a certain conventional standard. Now, how do you do that with a borderline person? I had a borderline client once who was smashing things around him. He would go to a pub with friends, and then he would break glasses and plates and enter into fights. And he would basically, this was one of those criteria described as severe reactivity of mood, leading to marked instability, mood swings, intense anxiety, depression, irritability, etc., etc. And whenever I spoke to him afterwards and asked him about his views on why he broke things and why he assaulted people, his response was always the same. He would say, I was angry. In the same way in which If you asked me why I had a sandwich, I would tell you that I was hungry. To him, being angry was a completely sufficient explanation of why he had beaten someone up. In the same way in which, to me, being hungry is a sufficient explanation for having a sandwich. Now, how do you deal with such a theory? Other than by using walls, or restraints, or punishments, or figurative punishments through the psychotherapeutic contract. And this is where we are coming to what I was hoping to basically put forward as some kind of idea. And that is a way of moral re-education by defining the terms of our psychotherapeutic work once the transfer is sufficiently developed, once the client is sufficiently attached to us. Defining the terms of our psychotherapeutic work with the borderline patient in ways which provide clear boundaries. For example, by saying that if you break glass again, and if you continue to consider the fact that you were angry as sufficient justification for that, I will no longer work with you. And this is the assumption of what Lacan calls the signifier name of the Father. This is a moral re-education which is reminiscent of the way we bring up our children. How do we bring up our children? We always condition them in some ways. We don't condition them harshly, but we do offer them a perspective of losing something, some kind of support, some kind of approval by us if they do some things. Now, can we do that? Can we assume that role in working with personality disorders, which are described as moral personality deficiencies? And what kind of responsibility do we assume by doing that? We assume the responsibility of restructuring the normative field of vision of the person. But by doing so, we become increasingly indispensable in their future life. If they agree to follow us, if they agree to, accept our role as signifier name of the Father, according to Lacan, this is the very foundation of normalcy. And thus, if they allow us to rehabilitate either the repressed function of name of the Father in the case of neurosis, or the destroyed function of name of the Father in the case of psychosis, they will recover. But what will happen with our relationship? How long will we have to be there for them? And is this partly the reason why in psychoanalysis, the analysis and the psychotherapy itself is so long-lasting, that people maintain relationships with their psychotherapists for years? Is this because it is a matter of resocialization as Pinel believed, and it is a matter of restructuring one's ethical register as the register of one's personal truth, rather than one's immediate ideational register of emotional experiences and interpretations of the real? Do we become the symbolic resource? Do we become the stabilizing factor instead of the symptom? And how long are we prepared to stay there in that capacity, and at what cost to us? This is a scary thing about personality disorders, because they often react badly to abandonment, especially the borderlines. And the closer you become to them, the more you will hurt them if they feel that you've abandoned them. And it's very difficult to stop therapy, to terminate therapy with borderlines, because borderlines then turn on you. So what do you think about that? Can therapy be successful if it ends up in a sort of breakup between the therapist and the client? Can you envisage a successful therapeutic process in which you reject the client harbors an animosity to you, but continues to function, takes off, and is able to take that rejection. Can you envisage a successful therapeutic course in which the client would later say that you were a horrible therapist, but would demonstrate by their lives and by their actions that therapy had in fact been a success? Because most of us have had the experience where we felt that we were unsuccessful. At least I've had the experiences where I felt that I was unsuccessful with clients who were adamant that we were spectacularly successful, because they had done things in their lives which had, in my mind, had nothing to do with our therapy. In fact, they had done nothing in what I believed were the main areas where we should have worked. But other things had worked out for them in their lives in those periods, and they ascribed the reasons for success to the fact that they had started therapy. And sometimes we feel like frauds, at least I do, because when people believe that they have succeeded because of our therapy, and I believe that they haven't, that it has nothing to do with the therapy, that's frustrating. But can the opposite also be true in case of borderlines? If we agree to play the role of name of the father, and do we actually always have the role of the name of the father? But if we explicitly agree to play that role, to be a re-socializer, a moral re-educator, and end up breaking up with the client in the same way in which you would break up with a boyfriend or girlfriend or husband or wife, with a degree of animosity by the client, who then goes on and lives a successful life. Can the client's dissatisfaction be proportionate to the success of the therapy? Or is the therapy only a commercial category which is successful only if the client is happy with the product? Our children are often not happy with the way we value their choices and we direct them in their development. But the value of our strategies of bringing up our children is shown later in their lives, not by their immediate reactions of satisfaction and dissatisfaction. Sometimes, many years later, they become grateful to us for things that they used to be angry at us when they were little. Can the same be the case with clients? Group sessions. What do you mean, Miriam, by group sessions? Do you mean group sessions of borderlines working together? Yeah. Has everybody joined us now? Because I see some people were waiting to join. Maya was waiting. Yeah. Yeah, with group sessions, what's peculiar about group sessions? Yalom has written about this in his famous book on group psychotherapy. He says a particularity of the group session, and this is an interesting point which you put forward, Miriam, in the chat. Group sessions, unlike client to therapist sessions, allow the clients to experience the consensual validation. The consensual validation of the co-sufferers, of those who have their own problems or similar problems to the client. So as a person in group therapy goes through certain experiences with others, and this works in the same way in which a laboratory works. The approval or disapproval or reactions by those with whom one has intimate relationships in the group is later reverberates in one's relationships in the real life. So the way one behaves in real life, after a while, one starts behaving in the group in the same way. And the way the group corrects them also has repercussions on the way one works and with others in real life. I will correct myself more effectively if 5 or 6 people with whom I'm in the group react in the same way and tell me the same thing, because I care about them. This is consensual validation. Now, does that work for borderlines? You mentioned that a Swedish psychotherapist works with borderlines in groups. Now, do borderlines trust each other, given that they have all these problems with appreciating the views of others? They might be more difficult candidates for group psychotherapy than others. Because if you, could I let Marco in? I would if I knew how. Marco, yeah, here he is. If you walk into a group and there's a schizophrenic in the group, it is likely that that schizophrenic will be less conspicuous than normal members of the group, because he or she will likely be withdrawn and will not show elevated affect. But if you have a borderline, the borderline can often be confused for a manic patient, because the borderline will want to grab all of the attention. The borderline would want to be recognized. They will want to be acknowledged. They will want to stand out. They will want to reaffirm their identity to the extent to which they have a problem with their identity. Because their identity is unstable, they will insist on being acknowledged by the others, on their identity being acknowledged by the others, and they will be dominant. Now, how do you work with a group of borderlines? It could be hell. 6 borderlines in the same room. Perhaps the group that the Swedish therapist works with is with 1 borderline and 5 or 6 others. That might work. That might work, because that could correct the borderline's absence of emotional appreciation of the effect that they're having on others, right? But having 1 borderline in a group, I think, is destructive enough. And now, how do you? How would you see this assumption, this idea by psychotherapists that borderline is in fact mild schizophrenia, when the presentation of borderline is so different from the presentation of schizophrenia? It seems to me that the unifying concept is Freud's concept of theory. Both the borderline and schizophrenia are displaced theories of the world, and they are displaced in ways that are sufficiently odd to the way our own views are displaced, that we can consider them a mental disorder. The behavior of borderlines is different from the behavior of schizophrenics, perhaps because borderline is mild schizophrenia, because the level of disorganization is lower than an advanced schizophrenia, which means that a person with an advanced schizophrenia is hardly able to be dominant. Their disorganization, their psychic disorganization has progressed so far that they have difficulty communicating their withdrawal, and they only have occasional outbursts of paranoia or various other types of ideation. But the borderline is sufficiently organized to cause trouble, and yet their theory is sufficiently displaced to justify that troublesome behavior. And this is basically a theoretical explanation, a potential possible theoretical explanation of what I just mentioned, where the person says, I break everything up because I'm angry. It's a theory, but at the same time, there's a sufficient level of organization for them to be dangerous. A schizophrenic is hardly dangerous. Occasionally they do terrible things, but very rarely. And arguably much more rarely than healthy people who commit crimes. But when they're schizophrenics, this achieves a high level of publicity, right? Now, to what extent can we then consider all of the personality disorders, especially the cluster B personality disorders, displace theories of reality which are primarily displaced in the ethical realm. Can we interpret this idea that they are ethical, moral personality disorders as them being warped ethical theories of reality? Can we reinterpret cluster B personality disorders as ethical problems, as problems of ethical reconsolidation, in fact, of ethical upbringing or re-upbringing or reformation? And to what extent is this connectable with our general views of psychosis? It seems that the difference between the personality disorders, the cluster B personality disorders, and the psychosis as we dominantly perceive them, is exactly in what Fahad defines as the truth lying in the realm of ethics. The schizophrenic wonders about the realism of one's perceptions of the world, primarily in epistemological terms. Whether the voices that I hear are real, whether the visions that I see are real, whether the touch of wood is really based on me touching wood, or is my sensation of touching wood, in fact, arising from me touching metal? These are epistemological questions. And most psychotics, when they report for treatment, they report epistemological queries, epistemological uncertainties, whereas the borderlines and cluster B personality disorders report ethical uncertainties, ethical problems, ethical misunderstandings, ethical divergences with the judgments of others. And could it be that the Lacanians view that psychosis begin with personality disorders can be translated onto a more general methodological plane, where we could say that epistemological disturbances arise from initial ethical disturbances, that once we lose the ethical orientation in what we do, it is only a matter of time, if it is left untreated, before we start losing our epistemological bearings, because our epistemological bearings are our theory of the world. And our theory of the world is methodologically normative, just as ethics is. Our epistemological theory of the world is also normative. Once the normativity of the way we think becomes too voluntary and becomes too displaced compared to the mainstream standard, it could be only a matter of time before our epistemology, what is true and what is not true, what we know, what we don't know, is also lost. And if we look at the politicians, because as far as I can see, they're only members of this group who come from a single country now. If we look at the politicians, how they progress from being challenged on ethical grounds to being challenged on psychiatric grounds, and this typically means being challenged on the realism of their perception of reality and public opinion and general interest. It is often the case that ethical controversies precede the epistemological controversies. This man has done so many things wrong, and now the question arises whether he even knows what is right and what is wrong, whether he even knows what he is doing. And we all obviously all know who we are talking about. Now, could that be a general continuum, methodological continuum between neurosis and psychosis? Because one of the Lacanian main themes is that neurosis and psychosis are structurally different disorders, but that neurotic symptoms can grow into psychotic symptoms if the disturbances to the socializing standard, to the role of the father signify, progresses from being blocked to being destroyed, to being removed. is it true that starting with the poor socialization, or with falling apart from what used to be good socialization, or falling apart from ethical exemplariness, if you want, we start falling into what could become epistemological relativism and the displacement of our very epistemic view of what norms are, what standards are, where we could be called crazy after a while. Anyone? If there are no comments, I don't think that I would want to continue for too long, because this is not a lecture. I just wanted to put forward some dilemmas for thought and some potential ideas for understanding the psychoanalytic view of displacement. If we're all displaced in our view of reality, is then the nature of our displacement what connects neurosis and psychosis? Is then the progression from the ethical displacement to the epistemic displacement what connects personality disorders with psychosis? Could that be a hypothesis? Could that be a workable theory? I'm not sure whether it can or not can't, but it seems as a promising idea to me, at least. Andrea, can you hear me? Okay. I think we have basically, I have said everything that I had to say in terms of this ex cathedra speech, which I didn't intend to give. So if there are any more comments, please go ahead. And if not, then we will post this recording and potentially talk about these same topics later on once we had time to consider them in more detail. No comments? Okay. Then thanks for listening. Thanks for being here with us. And let us then see how this will work. The recording will work, and then we can discuss this in our individual sessions, at least very briefly once we see each other, and potentially in our next group session. Andrea, do you have any news about the peer group? Is there?
I have some new people that wants to join us, and I just have to know the next date and the topic.
Okay. Does anybody have an idea about the topic? Okay. Okay. I will then think about this and circulate potential ideas for a topic, and then we can choose one topic and decide on a date. Did we say anything tentative about the date? When approximately it would be? Did we mention something? Did we mention like mid-December or something like that? You don't know. Okay. Okay. Good. Thank you very much.
Maybe just Saturday is not a good day.
Saturday is not a good day. Okay.
Maybe yes. Maybe some other day.
Would you like it to be Saturday or working day? Who's for of all of you who are present? Saturday or weekday? Okay. Nobody has anything to say this evening. Okay, we'll consult on the Viber, and then I will send a few, 2 or 3 topics to choose from, and then we can set a date for the peer group. The peer group is in our language, right? Is it? Will we hold it in English or in Croatian, Serbian? Andrea, what do you think?
Maybe maybe not in English, because I don't know. Maybe I can ask everybody.
Yeah. Okay. Okay. Thanks very much. Thanks for being with us this evening. And then I'll let you know once I find out whether this recording has worked out, and then we can talk about it later. Okay? Have a nice evening. Thanks a lot. Hey, by the way, I wanted to say that this evening we awarded certificates to our colleagues. Alexa, Maya, and Marco have received first certificates. Andrea has received the first certificate. She will get hers in the mail because she's not with us physically. And Thea has received the final certificate. She has finished the whole training program. So congratulations to them all. Okay. Right. See you, and we'll be in touch then in the more conventional ways on Viber. Bye-bye.